So after two very engaging talks, moving on to the third talk, that is about neonatal thrombocytopenia. There are not many like people who would be dealing with neonates day in day out, of course, other than pediatric residents. So I try to keep the topic short. Actually, if you read the topic entirely, it is like given quite in detail in some of the books. My job today is not to discuss much about all the pathophysiology and the flow charts. There are certain practice points which I would like all the residents to know, so that when you are treating the patient bedside, they'll definitely help you. And actually, the topic given to me was about approach to neonatal thrombocytopenia. I have took a liberty on my side and I have modified the topic a little bit just to go beyond the approach. So, like as it reads, do we actually know what we assume we know? Okay. So, to the residents in pediatrics, exam going residents, which is the most common hematological abnormality you see in the neonates? Most common hematological abnormality. Just because the topic is thrombocytopenia, the answer will not be thrombocytopenia. It is actually anemia. I am talking about neonates in general. Okay. So you do not see thrombocytopenia in stable neonates. Of course, the most common cause of most common hematological abnormality you see in NICU. In sick babies, it is thrombocytopenia. But in general, it would be anemia. Right. So the outline for talk today would be I'll be discussing in brief about the definition part. Then next is the incidence of thrombocytopenia, approach to a baby with thrombocytopenia, and what are the controversies surrounding the diagnosis and management of thrombocytopenia in neonates. So coming to the definition part, so traditionally in almost all the textbooks, the definition of thrombocytopenia which has been given for neonates, it is any platelet count which is less than 1.5 lakh. Further, on the basis of severity or on the basis of the platelet count, we can classify it as mild, moderate, and severe. So if it is between 1 to 1.5 lakh, you classify it as mild. If it is between 0.5 to 1 lakh, then you classify it as moderate. And if it is less than 0.5 lakh or less than 50,000, classify it as severe thrombocytopenia. A little bit about the incidence. So as I told, it is actually the second most common hematological abnormality in the neonates overall. This includes all the newborns. Okay. But if you talk about the sick neonates in ICU, definitely it is the most common hematological abnormality in some of these studies, though it has not been validated. And the overall incidence in neonates, it is around 0.7 to 0.9%. But if you talk about neonates who are admitted to NICU, it is around 18 to 35% in various studies. The incidence can sometimes be very high in certain sick newborns. So if you talk about the extreme low birth weight babies who are less than 1 kg, who are admitted to the unit. Some of the studies from Western world, they have shown that the incidence can be as high as up to 70%. That was the Western data. Maybe we do not have any Indian data on this topic, but maybe I strongly feel that the incidence would even be higher if you talk about the Indian data. Problem is, हमारे यहाँ पे कई बार ELBWs इतने बचते ही नहीं कि हम thrombocytopenia देखें, ठीक है? So the incidence I feel it would be on the higher side in ELBWs. So then coming to approach to a baby with thrombocytopenia. So if you look at the causes for thrombocytopenia, there are actually a lot of causes. Can be like anything from sepsis, DIC, pouch infections, perinatal asphyxia, albumin thrombocytopenia, autoimmune thrombocytopenia, or sometimes some other conditions like thrombosis due to renal vein thrombosis, or maybe inborn errors of metabolism, chromosomal abnormalities, certain viral infections, or it may be drug induced. So there are many different conditions which would lead to thrombocytopenia. If you are to delineate the cause, the first approach would be that we have to answer two questions, or we have to look for two things. First is, what is the age of onset of thrombocytopenia? In a newborn, if you are having a newborn who is having thrombocytopenia, first of all, you have to find out the age at which the thrombocytopenia was first noticed. So if it is at less than 72 hours, the causes would be different and the approach would be different. And if it is at more than 72 hours, the approach would be slightly different. Then 72 hours of age. Okay. And second thing is, you have to look at the clinical condition of the newborn, whether the child is clinically stable or clinically ill. So based on these two questions, we can proceed ahead. Actually, the flowchart is given in almost all the textbooks. I would want to go fast on this flowchart because I think it is self-explanatory. I would rather want to focus on certain other topics in the end. So, if you are having a child who is presenting to you with thrombocytopenia in the first 72 hours of life, and if the child is clinically well, then you have to look for whether the thrombocytopenia is mild to moderate. So, if you have a well-appearing newborn and the thrombocytopenia is mild to moderate, the most common cause is placental insufficiency. Okay, sometimes when the fetus in utero is not getting enough placental blood supply, there will be chronic in utero hypoxia. Because of the chronic in utero hypoxia, the bone marrow gets suppressed, and so these babies will have thrombocytopenia, mild to moderate thrombocytopenia in the first few days of life. It usually tends to resolve on itself by day 10, and the child will almost always be normal all throughout the course. So if that is the condition, no further evaluation needed. By day 10, you will see that these platelets start to rise. But on the other hand, if there is, if the child is having severe thrombocytopenia and you feel that the platelets are not rising, then you have to think of something else. Again, the most common differential would be sepsis. Why are we worried about sepsis? Because you should not delay the diagnosis of sepsis. A case missed will lead to can lead to a loss of life. So again, if you are not sure that it is due to placental insufficiency or if the thrombocytopenia is severe, it is better to evaluate for sepsis or DIC. If that is ruled out, we have to look for autoimmune or autoimmune thrombocytopenia. So NAIT stands for anyone? What is NAIT? NAIT. Neonatal alloimmune thrombocytopenia. Okay, so what happens usually sometimes the fetus, when the fetus is in utero, will have certain platelet antigens which are derived from the father, but they are absent in the mother. So whenever there is exposure of those paternal platelet antigens to the mother's serum, mother will start producing anti-platelet antibodies which are directed against the paternal antigen, human platelet antigen, and so when the child is born, the child will otherwise be well appearing, but he will have severe thrombocytopenia and it may even present with intracranial bleeds. Okay. If you have ruled out alloimmune and autoimmune causes of thrombocytopenia, then you have to look for other causes. Similarly, if the child is clinically well but is having severe thrombocytopenia, of course, first thing I would want to do is I would want to rule out sepsis or DIC. After that, I would want to look for again alloimmune or autoimmune thrombocytopenia, and then maybe we can consider other causes. And if the child is clinically ill, then definitely there is no doubt. First thing you have to rule out is you have to rule out sepsis or DIC, followed by NAIT and other causes. If it is a late onset thrombocytopenia, again, if you have to look for whether the child is clinically ill or well. So if you have a sick looking child, again, you have to evaluate for bacterial or fungal infections. If that is ruled out, then you look for other causes. If the child is clinically well, you feel strongly that it does not correlate with sepsis, then you should find out for a history of central line in situ, or maybe there is a history of central line being present earlier. So many times it happens that we have a child with hypoglycemia, persistent hypoglycemia, we put a central line to give higher concentration of dextrose. So those babies, because of that central line which was inserted earlier, sometimes they may have some catheter associated thrombosis, and that may be a cause for thrombocytopenia. And you have to look for medication history because it is not very uncommon for neonates to have thrombocytopenia secondary to medications which we are using. So drug-induced thrombocytopenia can be a possibility. If all that is ruled out, you have to look for other causes. Now, for these other causes which I have been speaking, so first and foremost, you should have a detailed history. You should ask for maternal thrombocytopenia to rule out autoimmune causes. So if the mother also has thrombocytopenia and the child or the baby has thrombocytopenia, then it has autoimmune thrombocytopenia. Second is to go for physical examination to look for dysmorphic features which may be associated with certain trisomies. Then physical examination again to look for hepatosplenomegaly or direct jaundice which may be associated with pouch infections. Again, in physical examination, if the child is having encephalopathy and seizures, it may be inborn error of metabolism. If there are any abnormalities of the upper limb, sometimes it may be thrombocytopenia, absent radius syndrome, or congenital amyloidocytic thrombocytopenia. And finally, we should look for the platelet morphology in peripheral smear. If still you are not able to find out the cause, it is better to go for a genetic biopsy. So this would be the approach to thrombocytopenia. I think it is most of it is self-explanatory and it is given in almost all the books. I would rather be more interested in the next few slides. So Talking about the mechanisms for thrombocytopenia, as Sir had also told in his slides, that there are two broad categories. One, it can be due to decreased production of platelets, or it can be due to increased destruction. So sometimes, just by simply looking at a CBC report, you can get an idea as to what is actually the cause. Okay, it happens with us many times that when we are in the NICU, we keep on treating thrombocytopenia, unaware what is the diagnosis. We send blood culture that is coming negative. The child is improving, but the thrombocytopenia is not improving. Okay, your platelets are still sitting at 5,000, 7,000, 8,000. The child is clinically improving, and then we keep on asking ourselves what is the cause. If it was sepsis, it should have improved. Why it is not improved? Okay. So there are very simple tests which will help us to differentiate whether the thrombocytopenia is actually due to increased destruction or it is due to decreased production. Okay. So so there are four tests which I would like to highlight. So first is the immature platelet fraction. Second is the mean platelet volume in the CBC. Third is the reticulated platelets percentage and thrombopoietin levels. So again, immature platelet fraction, actually we do not take it in our CBC reports, but there are certain blood analyzers which in the CBC report itself, they will give you the immature platelet fraction. Okay, and it is actually nothing but the young platelets as compared to the mature platelets in the peripheral circulation. And we have charts available or graphs available which we can use to find out how much is your immature platelet fraction. So if your immature platelet fraction is on the higher side, it means that the bone marrow is trying to compensate for thrombocytopenia, and you can be sure that it is because of increased destruction and not due to decreased production. Similarly, the mean platelet volume, similar to what we use for anemia. Like for anemia, if you want to find out the cause, we have the habit of looking at the reticulocyte counts. Similarly, mean platelet volume, these are actually immature platelets. When they enter the circulation, some of them will be larger in size, some of them will be normal in size. So the mean platelet volume will be on the higher side. Okay, and so if you have a child where the mean platelet volume is on the higher side, you can assume that it is because of the increased destruction. Reticulated platelets, again similar to the reticulocytes, the immature platelets which are entering into the circulation can be detected. And if the amount is high, that is more than 10%, again you can say that there is increased consumption of the platelets. And lastly, the thrombopoietin levels. So if for some reason the thrombopoietin levels are on the lower side, then you can assume that it is because of increased destruction. Whereas if the thrombopoietin levels are on the higher side, then it is because of the decreased production. Okay, but still, this is actually primarily a research tool. Then, so till now, I think things were very clear. Okay, we had a look at the diagnosis, the approach to a child with thrombocytopenia, and a little bit about the definitions. Okay, now coming to the controversial part, that is management of thrombocytopenia. If I was the resident sitting there, I would think management में क्या है? कुछ नहीं, platelet come and platelet चला, ठीक है? That is what we do most of the times. So what is the controversy? So actually there is a lot of debate going on about this topic. Okay, like when to treat, with what to treat, and like what should be the ideal threshold for transmission of our treatment of neonatal thrombocytopenia. So first controversy is like, is the definition correct? So हमने अभी कहा क्या देखा last few slides में, any platelet count which was less than 1.5 lakh was called thrombocytopenia as per the traditional age-old definitions. Okay. Now we are in the era of evidence-based medicine. Everything has to be evidence-based. You look for evidence for each and everything which you do or which you decide for your patient has to be evidence-based. Okay. So in the recent times, though most of the literature says that any platelet count less than 1.5 lakh is normal, the problem is that there have been many population-based studies where they have found that the fifth percentile of the normal platelet. So they examined healthy neonates without any disease. The child was otherwise healthy. If you plot the platelet count of the entire population which was screened, there were quite a few babies. This time normally platelet count at birth was 1.05 lakh for premature babies less than 32 weeks. And for bigger babies, that is for your late preterm and term babies, the normal platelet count can sometimes be as low as 1.23 lakhs. Okay. So the lower limit of normal in many of these studies has actually been found to be less than the cutoff which we use. So this suggests that we need to have a separate definition for thrombocytopenia for preterms. Unfortunately, we don't have it now. Maybe in the coming few years we may have it. Okay. So this is actually from one of these studies where they have plotted the platelet counts of the neonates at various gestations. And you can see the last graph. Okay, so almost all at any gestation, the lowest platelet count for normal neonates was around 1 lakh. Okay, and हमारा cutoff क्या था thrombocytopenia का? Less than 1.5. Okay, so if you go by this population data, a large number of your neonates may actually be normal and you may classify them as thrombocytopenia. So first controversy is that we are not still sure what is the actual definition. Second, हम लोग thrombocytopenia देख के क्यों घबरा जाते हैं सब लोग, जैसे सर ने बोला था bleeding होगा है ना, कंसर्न ही सबको ये होता है कि प्लेटलेट कम है मतलब bleeding होगा, ठीक है. Let us look at the evidence. So this was one of the landmark trials. If you talk about the this thing evidence for adult medicine, there is a lot of evidence. Neonatology, it is still an evolving branch. We are not very old as a branch. So for many of the treatments which we use for neonates, it has percolated from adult medicine to pediatrics and then to neonates. Okay. As such, for neonatal medicine, there is evidence not available for many of the therapies or many of the treatments. So in the year 2013, this trial was published, okay, and it is one of the landmark observational trials called the Planet 1 trial. What they told us that there is a poor correlation between the degree of thrombocytopenia and the incidence of bleeding, which means if अगर आपका platelet count 5,000 भी है, it does not mean that the child will have significant bleeding. So the severity of thrombocytopenia and the risk of bleeding is not very well correlated. Okay, and this was from almost newborn population of up to 1 lakh. Okay, इतनी ज़्यादा बड़ी population में what they concluded is it is not necessary कि अगर आपका platelet count कम है तो आपका bleeding का risk बढ़ेगा, and there is not very good correlation. Also, what they concluded is that giving platelet transfusion does not decrease the risk of intraventricular bleeds. ठीक है, तो कई बार जब हम premature babies को deal कर रहे थे, we are very much worried about कि प्लेटलेट कम हो गए ब्लीड हो जाएगा, ठीक है, अल्ट्रासाउंड कराओ एवरी 6 आवर 12 आवर में वी कीप ऑन डूइंग अल्ट्रासाउंड्स बिकॉज़ वी आर वेरी कि ब्लीड्स हो जाएंगे, ठीक है. सो व्हाट दीस स्टडीज दे टोल्ड कि इवन इफ द प्लेटलेट काउंट इज लो, इट डज नॉट necessarily increase the risk of IVH. The strongest predictors for a risk of bleeding in any neonate was gestational age less than 28 weeks, postnatal age less than 10 days, and presence of necrotizing enterocolitis. Only these three factors increase significantly the risk of bleeding in a neonate. The lowest platelet count was not very well correlated. Of course, अगर platelet count कम है तो risk of bleeding थोड़ा बढ़ेगा, but it does not linearly correlate with the increased risk of bleeding or hemorrhage. So this paradoxical finding. So how do you explain that? The platelet count कम है फिर क्यों bleed नहीं हो रहा है newborns में? So why? Because in neonates they usually have a high hematocrit. There is high MCV and also high concentration of von-Willebrand factor, and this to some extent compensates for the thrombocytopenia which a neonate may have. Okay, so as a result, they will all these three factors which I mentioned, they will create a pro-thrombotic environment, and they will to some extent compensate for the less number of platelets. Then third controversy is when to transfuse platelets. ठीक है, जैसे मैंने बताया severe thrombocytopenia का definition क्या है? Anything less than 50,000. So when I was an MD resident in 2015-16, रात के 2 बजे CBC का रिपोर्ट आया, प्लेटलेट काउंट लेस देन 50,000. अब क्या है क्यों है उतना तो किसी रेजिडेंट का दिमाग चलता नहीं, मेरा भी नहीं चलता था. तो एक ही फाइनल एक्शन क्या होता था, प्लेटलेट कम, RDP मंगाओ चढ़ाओ, ठीक है. What is the problem? ठीक है. So there have been many studies which have been done in the last few years about what should be your threshold for transfusion. जब मैं resident था 7-8 years back, we used to transfuse any child with a platelet count less than 50,000. We will transfuse कि भाई bleeding हो जाएगा, इसलिए prophylactically हमने platelet चढ़ा दिया, ठीक है. अभी हम कितने पे transfuse करते हैं? What is our cutoff? So let us see what the evidence says. So again, this is again one more landmark trials which all of us as pediatricians and neonatologists we should know. It was published in 2019. ठीक है, तब तक मेरा MD खत्म हो गया था. So 2019 में when this trial was published, it was Planet 2 trial. Planet stands for platelets for neonatal thrombocytopenia. ठीक है, so Planet 2 trial which was published in 2019. What it compared? They compared प्लेटलेट ट्रांसमिशन थ्रेशोल्ड ऑफ 25,000 विद 50,000, ठीक है। वहां पे ऑथर्स ने क्या सोचा कि 50,000 पे तो इतना ज्यादा कुछ सिग्निफिकेंट ब्लीडिंग रिस्क है नहीं, तो लेट अस कंपेयर कि 25,000 तक अगर हम वेट करें तो whether it is okay to wait till 25,000 or we should transfuse at 50,000, ठीक है। They wanted to see कि 25,000 पे अगर आपने ट्रांसफ्यूज कर दिया तो उससे क्या मोर्टेलिटी बढ़ेगी। So to their surprise, what results showed that there was higher incidence of death and neurodevelopmental impairment at 2 years corrected age and higher incidence of BPD, that is bronchopulmonary dysplasia in the high transfusion group। मतलब जिस बच्चे को 50,000 के नीचे जाते ही आपने बार बार प्लेटलेट चढ़ाए, उन बच्चों में मोर्टेलिटी के चांसेस बढ़ जाएंगे, ठीक है। दिस इज कॉन्ट्ररी टू व्हाट कॉमन सेंस है ना। हमारा कॉमन सेंस क्या बोलता है, प्लेटलेट कम है चढ़ा दो प्लेटलेट, ठीक है। बट टू देयर सरप्राइज व्हाट दे फाउंड इज कि जिन बच्चों में बहुत अग्रेसिवली आप प्लेटलेट ट्रांसफ्यूजन कर रहे हो उनमें मोर्टेलिटी ज्यादा है। नॉट ओनली द मोर्टेलिटी, द न्यूरोडेवलपमेंटल आउटकम एट 2 years of age was bad, ठीक है। So somehow even if you are able to save the child will become CP and he's of like no contribution to the society, ठीक है। So why so? Let us look at the reasons. So because of this trial, ठीक है, जब ये ट्रायल आया इससे पहले का, I mean I have read Clover T in 2017 also जब मैं एनजी में था, और अभी का रिसेंट एडिशन भी मैंने पढ़ा है। So जैसे ही ये ट्रायल आया सारी टेक्स्ट बुक्स में प्लेटलेट ट्रांसमिशन की गाइडलाइंस दे चेंज, ठीक है। Why? All these guidelines are because of this particular landmark trial. So now all the guidelines they say that you have to wait till 25,000. At less than 25,000, you can go ahead and give platelet transfusion. 25 to 49, if there is a major bleed which was present in the last 48 hours, and between 50 to 50,000 to 1 lakh, only if the child is having alluvial thrombocytopenia with a major intracranial bleed. Otherwise, do not transfuse platelets. Then one more controversy, what should be the speed of administration? हम लोग कैसे चढ़ाते हैं प्लेटलेट? 20 minutes, है ना। जितना आए जितना जल्दी चढ़ाओ, हमारा क्राइटेरिया क्या है, जितना जल्दी चढ़ा सको चढ़ा दो। ऐसे कि चढ़ाया अभी और उसका प्लेटलेट नॉर्मल हो जाएगा, ठीक है। व्हाट इज द प्रॉब्लम? सो अगर हम किसी प्रीटर्म बच्चे में बोलस नहीं देते हैं, क्यों नहीं देते हैं बोलस की? ब्लीड हो जाएगा, है ना। और एक्स्ट्रा सडनली इतना ज्यादा वॉल्यूम किसी बच्चे में will lead to cardiovascular instability. अगर हम फ्लूइड नहीं दे रहे हैं उसको तो why we are giving so much platelet rapidly, ठीक है। So this trial they actually tried to compare कि अगर हम 30 minutes में platelet transfusion दे और 2 hours में slowly platelet transfusion दे तो what was the difference? And what they found is that the transfusion duration actually does not affect the final platelet count, ठीक है। तो अगर आप 2 घंटे में दोगे तो भी प्लेटलेट उतना ही रहेगा, आप आधे घंटे में दोगे तो भी उतना ही रहेगा, ठीक है। एंड द पोस्ट ट्रांसफ्यूजन प्लेटलेट काउंट वाज सिमिलर, बट द फास्टर ट्रांसफ्यूजन रेट, मतलब अगर आप 30 मिनट्स में फटाफट प्लेटलेट दे रहे हो, यू आर एक्चुअली इंक्रीजिंग द चांसेस ऑफ इंट्रावेंट्रिकुलर ब्लीड, ठीक है। सो इवन स्टैंडर्ड टेक्स्ट बुक्स लाइक Clover T they now mention that transfusion has to be given slowly over a period of 2 hours, ठीक है। Maybe one thing which we have to change in our practice now. So what is the effect of transfusion? जो कंट्रोवर्सी थी सबसे पहले कि क्यों प्लेटलेट्स चढ़ाने से बच्चे की मोर्टेलिटी बढ़ गई, ठीक है। what is the controversy in that? So what happens is कि जहां तक हमारी अंडरस्टैंडिंग है, प्लेटलेट मतलब क्या, ब्लीडिंग कम करने का ब्लड फैक्टर, है ना। इट इज नॉट सो सिंपल। प्लेटलेट्स हैव गॉट मेनी अदर फंक्शंस अदर देन द हीमोस्टैसिस। तो ब्लड को रोकना तो है ही उसका, आई मीन आपका ब्लड लॉस रोकना तो है ही उसका प्राइमरी काम, but there are many other functions which a platelet has to do. That is, one is response to infection, second is it will activate the immune cells, third is it will regulate the vascular tone, it is responsible for angiogenesis, platelets are responsible for cytokine release and local inflammation also, ठीक है। तो आजकल, I mean sir is here about this, आजकल we are not looking at platelets only as a blood component, it is also a component of the immune system, ठीक है। So it has got role both in hemostasis as well as immune function. So what is the problem? हम जब भी platelet transfusion देते हैं, all those are adult platelets, ठीक है। Adult platelets as compared to the neonatal platelets, they are hemostatically and immunologically more active. मतलब ब्लीडिंग रोकने की कैपेसिटी उनकी ज्यादा है और साथ ही साथ में they are immunologically more active, ठीक है। तो अगर हम किसी बच्चे को ब्लीडिंग रोकने के लिए अडल्ट प्लेटलेट्स ट्रांसफ्यूज कर रहे हैं तो डेफिनेटली हम उसका ब्लीडिंग रिस्क शायद कम कर देंगे, बिकॉज अडल्ट प्लेटलेट्स आर मोर एक्टिव। Problem कहाँ है कि you are also disturbing the immune system of the newborn. ठीक है, because newborn के जो actual खुद के platelets हैं, they are not very immunologically active. But जब हम किसी adult का platelet transfusion उसको चढ़ाते हैं, random donor platelet जब हम किसी adult से लिया हुआ बच्चे को चढ़ाते हैं, this causes a disturbance in the neonatal immune system. ठीक है, so what happens is when you transfuse the adult blood, there is increased release of cytokines and chemokines. There is increased neutrophil activation. There is increased activation of P-selectin. And what are the side effects? जैसे ही हमने किसी न्यूबॉर्न को adult platelets चढ़ाए, problem कहाँ होगी? There is more of microthrombi which will be formed in the circulation. There is more activation of cytokines, more inflammation in the body, more immune cells will be locally activated, and all this will lead to certain disorders which are associated with immune dysregulation, like BPD and periventricular leukomalacia. Okay. So, and other than that, there are two more concerns in transfusing platelets to newborns. One is that there is transfusion transmitted CMV infection. We have had cases in the past जहाँ पे premature baby था, thrombocytopenia was refractory. We were not able to find a cause. Ultimately, हमने CMV भेजा and it came positive. So where did that CMV come from? Maybe the transfusions which the child would have received initially led to a acquired CMV. Second is transfusion associated graft versus host disease. ठीक है? I do not know यहाँ पे कितने residents ने कितनी बार देखा है. I have seen patients in my residency. हमने platelet transfusion चढ़ाया या PCV चढ़ाया and the neonate deteriorated and died. ठीक है? So it can lead to a graft versus host disease because your newborn is immunologically compromised, and whatever you are transfusing can have certain active immune cells. Right? So key takeaways are that neonatal thrombocytopenia is a common finding in sick neonates. However, the severity of thrombocytopenia does not correlate directly with the risk of bleeding. So in babies with thrombocytopenia, our focus should be to find out the etiology and treat it rather than giving aggressive platelet transfusions unless there is a risk of unless there is an evidence of bleeding. And lower platelet count threshold, that is, you should wait for lower platelet count to decide on transfusion because it is associated with lesser mortality and better neurodevelopmental outcomes. And transfusing adult platelets to neonates will disturb the hemostatic and immune milieu in the newborns. Thank you.